Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. Welcome to the show. If you're watching us live, great. Glad to have you on board. Be sure to hit that subscribe button. Also, go to check out our website if this is your first time seeing us at euronurse.com, where you'll be able to see more about the show and learn more about the show and about all of our 100 past episodes. That's right, 100 past episodes that you can check out. Want to listen to us in your car? No problemo. Just go to our Euronurse Plus area where you can check out our audio podcast on any of your favorite podcasting apps. This week, we got a great show. It's going to be talking about PSA, and this is one of our contact hour presentations. So at the end, you will be able to go to our website and find out information to receive your one contact hour. And with that, let's go ahead and bring in our experts. Welcome to the show. Hey, John, welcome. How are you doing today?
Hey, good morning.
Nice. All right. John and I were talking earlier. He just got back from a cruise. I'm jealous. I've done a lot of cruises. I mean, like in the 30s of cruises, but never cruised Europe. I've always traveled by plane there. So I think that's a great way to see Europe. Anyway, I'm Vic Sinise. I am your host. I've been with the show forever, started the show, created it, and been in urology for the past 40 years and just love to be able to give back. Interesting story. I hope everybody's had a great 4th of July. I was lucky enough to have my grandkids from the Florida area, 6 of them come in, and I've got 2 of them that are gymnasts, and we were out on the boat, and you can see why they're gymnasts. No matter what wave I hit, they could hang on to anything. That gymnastic training, that core strength, they did great. So if I guess they give up gymnastics, they can try the rodeo. It was a lot of fun seeing them for the short weekend or the short week. All right, John, welcome. Give us your introduction.
Well, happy July 4th weekend. I am passionate about helping urology practices succeed so they can reach maximum clinical and financial efficiency. And to that end, I created a thriving urology practice Facebook group where we crowdsource practice management solutions for everyone's benefit, and it is all for free. I frequently speak on the topics of coding, billing, revenue cycle management, marketing, and how to run your practices more efficiently in the era of declining reimbursement and rising overhead costs. I just spoke at the AUA annual meeting and the Texas Urological Society meeting recently, and I will be at the South Central Section AUA meeting in October, and finally, Urology Advanced Coding and Reimbursement Seminar in December. I am John Lynn, a private practice urologist in Gilbert, Arizona, and I look forward to our discussion today about PSAs, something that hopefully will be less mysterious to you after the presentation. Back to you, Vic.
Great. Now I got to ask you, I see you got a logo on your shirt that I don't recognize. Usually it's the Sunshine Urology.
Sunrise Urology, yeah.
So what's this one?
This is Northern Arizona University.
Oh, okay. Very cool. All right. Well, let's get with our show right now. We're going to bring on our speaker and go ahead.
It is a pleasure to welcome back faculty that you guys know pretty well, Dr. Matt Rosenberg. Dr. Rosenberg is a director at Mid-Michigan Health Centers in Jackson, Michigan. Matt, welcome. Glad you're here with us today.
Simon, thank you so much for inviting me.
My pleasure. Always good to work with you on these. Here's Matt's affiliations and his disclosures. Our learning objectives for this hour discuss the current approach to prostate cancer screening with PSA, interpret PSA levels based on cutoffs and patient characteristics, and utilize biomarkers beyond PSA when appropriate to further quantify cancer risk. All right, that does it for me for right now, Matt. I'm going to go ahead and hand it over to you. Let you get us started here, and I will see you back with some questions about halfway through.
All right, Simon, thank you so much. And I want to thank everyone for taking some time this morning to listen to a talk. And, Simon, you and the group are nice enough to allow me to go unplugged on this session, really just talk about what I've learned in the world of prostate cancer screening. And, let's start with it's tough. I mean, there's a lot of information, maybe some misinformation, confusing information on what we should be doing for prostate cancer screening from a primary care standpoint. And as you know, I'm a primary care provider. I have a background in urology, so I probably know a lot. I know a lot about this. I probably know more than most of my colleagues in primary care because I studied this. And my goal today is to really open up the lines of communication. I'm not going to tell you what you should do, but I'm going to give you the information to understand what you can do to help your patients. Now, the title of my slide, or my slide set, my presentation today, is Evaluating for Prostate Cancer, the Good, the Bad, the Ugly. And Simon, the more I think about this, I probably should have started it, the bad, the ugly, and the good. Because we're going to start with talking about what is prostate cancer and what is the problem that we're having. And then hopefully at the end of this, I'm going to give you a solution for what you can do to help your patients better in your busy clinical practice. And, I like to start a talk by giving you my conclusion. And I'll talk about this at the end, at the conclusion. And the conclusion is prostate cancer screening is very, very important, but it has to be done correctly. Now, why is it so important for the audience that we're talking to today? And that's because primary care does the majority of prostate cancer screening. The PCP, the primary care provider, does 90% of the PSAs that are done in the US. And that's data consistent every year. And the reality is screening is going to start with us. And it's very confusing. It's very confusing, and we need to know how to do it right. So let's start with the basics right now. What is prostate cancer? I mean, we all know about it. We all hear about it. It's the most common non-cutaneous cancer in men, at just under 300,000 incidents a year. It's actually way above lung and bronchus. Its mortality is just over 34,000, so for a percentage of 12%. So lung and bronchial cancer causes more death, 55% mortality, but prostate cancer is number 2, and it's not a far away number 2. So unfortunately, a lot of people die of prostate cancer, but when you get that overall number, the percentage is low, with a mortality of about 12%. And when we look at the risk of being diagnosed with prostate cancer in your life in the United States, I'm sorry, I just went too many slides, it's about 11% with a mortality of 2.5%. So yes, a lot of people get this, but most people don't end up dying of it. And here's a very interesting data. I just looked at this. I saw the paper just about a month or two ago when I was looking at the ethnic differences with prostate cancer. And different ethnic groups are more at risk for this. And we need to be aware of this. The mortality in African American males is much higher than others. So the question is why? Why are they dying more of prostate cancer than others? And again, that's going to lead us to the answer at the end, that appropriate screening is just that. It's appropriate, and we should be doing it. We should be doing it in the right patient. Now, as I mentioned, PSA is ordered mainly by primary care. We're the 90% of the ones in the US. In different countries, it is different. Now, what do we know about PSA? Well, PSA was developed in the late 80s. It was actually developed to follow prostate cancer. It wasn't developed to screen. And then I think it was University of WashU, in St. Louis is where it was developed. And they realized that it actually can be useful in screening. Now, PSA is prostate specific. The elevations occur with cancer, but that actually has a very poor sensitivity. It can also go up with BPH, benign prostatic hypertrophy. It can go up with prostatitis, with trauma, instrumentation. And here's a very interesting fact for all of us that we should know in our clinic, is it doesn't increase with sex or DRE. We were taught that years ago. It was actually an urban myth. We thought it went up. It actually doesn't. And patients will ask about that, but the reality is it doesn't go up with sex or DRE. A very interesting point here is this second bullet, 15% variation week to week. What does that mean? The PSA will go up and down. It actually varies depending on the assay. So if you have that borderline PSA and you're questioning what to do with it, the new rule is to check it again if you're going to check it because of that variable week to week. And I've certainly seen that in the clinic. And that's kind of we're paying a lot more attention to that than we did before. But the reality is when you look at this slide and the information, the PSA is as I titled, is not a great test, but it's a good test because it does give us information about the prostate. we started using the PSA in the late 80s, early 90s, and we started screening everybody. In fact, I remember my chairman on my program said, the PSA, what your PSA has become locker room talk now. Everybody knows what their PSA is because everybody's going to be getting it. But what happened is a lot of people are getting a PSA. There were elevations. A lot of people had surgery. And we started to realize that not everybody needed that. Not everybody needed surgery. Not everybody was going to have a prostate cancer that was going to do something to them, or a elevated PSA that meant cancer. And the bottom line is we were making a lot of needless patients and causing a lot of issues with that. And when we looked at the mass population studies, and these were done 15 years ago, they started actually about 20 years ago, we looked at mass screening on prostate cancer mortality. Now, the American study, the prostate, lung, colorectal, ovarian study, showed no benefit with screening. The European randomized study on prostate cancer showed a little bit of risk reduction in two subgroups, in 2 sites out of 7. So it really raised a lot of questions. Is this helpful? Because the questions that we were all asking is, wait a minute, there is a significant risk of overdiagnosis. A lot of people get too much treatment from this. So overdiagnosis drives overtreatment. And unfortunately, overtreatment results in economic loss and side effects. So when we have a limited test, which is the PSA, because it's not specific, we end up with a high false positive rate. Now let's look at the numbers. From this slide, you see over 1 million prostate biopsies performed annually in the US. Well, remember the data I just showed you a minute ago? There'll be under 300,000 men diagnosed with prostate cancer. 12% will die of prostate cancer. But 1 million biopsies, that means there's a lot more biopsies and patients are getting affected. And a lot of the biopsies have a low-grade indolent cancer, which is what we know as a Gleason grade 6, or no prostate cancer. And a biopsy is not benign. I mean, you're basically putting a needle into a prostate, and the risk of infection, hospitalization, mortality is, I don't want to say is high, but is there. And the question is, if we're doing a test that maybe there was something we should have done first, and why are we taking that risk? The counter to this, and we're going to talk about the guidelines in a few minutes, there were guidelines out there as maybe we shouldn't be screening for prostate cancer. And that's what the United States Preventive Services Task Force said in 2012. The problem is, if the PSA is all we got and we don't do it, then are we missing an opportunity to treat men who would benefit from that, the 12% of men who are going to die of this? Remember, for all of us who are my age, I've been practicing for over 20 years. We used to pick up prostate cancer when the patient would come to clinic or in the ER explaining of a new onset of excruciating back pain. They were metastatic by the time we found them. That's not good, certainly. And if we follow these recommendations as they are, we're going to miss an opportunity to find them. Adding to the problem, the PSA, if you talk to 6 doctors about what PSA we should be concerned about, you're going to get 6 different answers. Is it velocity? Is it 4.0? That was the old number. It's not 4.0 anymore, I'll tell you that. Is it density? Is it age changes? It gets really confusing. There's not a clear-cut answer on that. All right. So then it comes down to what should we follow as primary care providers? What should we follow? We don't know. We get a lot of different people giving a lot of different answers. So I have a summary here of the guidelines. All right. And if we look at the guidelines in 2023, the NCCN guidelines came out and said, shared decision-making for baseline PSA testing in patients 45 to 75 with a follow-up based on PSA value. There's a lot of variables in there, but that's what they're saying. In 2018, the United States Preventive Services Task Force said, you know what, we're going to change the grade to C. So the decisions to screen should be up to the individual, and it should be looking at men about 55 to 69. Again, we're giving it a grade C. It used to be a grade D. Okay, so that's maybe a little better, but don't screen over the age of 70. Okay, but when you read the guidelines, there's a lot of variability there. So the AUA and the Society for Urologic Oncology just about a month or 2 ago released their new guidelines. Actually, a good friend of mine was a lead author on that. And what they said was patients 50 to 69 should be offered prostate cancer every 2 to 4 years based on age, comorbidities, risk, and life expectancy. very readily saying there are a lot of variables in this. So I had one of my students, Evan Harold, and Evan, did a wonderful job basically summarizing the guidelines. I said, Evan, I want you to read these guidelines and write out an algorithm so that we can look at it if it makes sense. And this is what he came up with. And this is only the first page. There's a second page to this. And I'll be honest with you, he's showing me this, and we're both cringing. Wait a minute. This is the guideline that the primary care provider is supposed to follow. We have the screening, and then we have age changes and risk changes, and depends on what your level was, and depends on shared decision. And should we follow in 1 year, 2 year, 4 years, and depends on your risk. And it's like the smoke is coming out of our ears because we're getting confused. We don't know what to do. They're not easy. So the AUA guidelines in 2023, in my mind, actually made it harder for us. I was hoping it would make it easier. It actually made it harder. Now, when you look back at all of the guidelines, there's something that they all say, which is we should do shared decision making. The patient should be involved in the process of whether or not to screen. All right. And when you look at the tenets of shared decision making, there are 3 tenets. There's provision of information, which is supposed to be balanced and evidence-based. There's the harms and benefits of each option should be discussed. We need to elicit the patient's perspective. We need to ask about prior experiences, understand and discuss their concerns, delineate their preferences. We need to guide them in the final decision-making process without directing them. These are the tenets of shared decision-making, and this is what we're supposed to do. And I will tell you, so I showed this to a friend of mine who's a urologic oncologist on the East Coast. And I said, you're an expert in this. If you were to do this process appropriately for every patient who comes in your office, who you're going to be screening, if you do screening, how long would this take? And mind you, this guy's a specialist. And he said 20 minutes at least. And I looked at this, I'm like, how is this possible? How can we be spending this kind of time? And he's a specialist. We're not, as primary care providers, we know a lot. I mean, we're the masters. Unfortunately, the masters of nothing, but we know everything, and that's what we do. We know everything about the patient. How could we, as not being masters of urology, how could we spend this kind of time with the patient and be able to explain it correctly? And when they looked at this in a national study, what they found out was we're not doing shared decision making. I mean, that's pretty obvious. When they looked and when they asked patients, these were patients who came out of an office who the doctors were told to, were saying to them, you need to do this process. Only 10% received all the tenets of shared decision making. When they looked at the numbers who ended up getting a PSA, it was about 55%. Only 22% understood that some doctors recommend the test and other doctors don't. And they were only 14% were informed that no one's sure if PSA's testing is saving life. So the reality is, as wonderful as the concept of shared decision making is, it is not useful in a primary care office. We can't do it. It's not feasible for us. So when I look at the guidelines, all 3 of them, and I say, you talk about shared decision making, that makes it too hard for us to be able to do it appropriately. And unfortunately, what happens, when we take the unnecessary procedures and the poor consensus on the PSA and the patient complications and the shared decision making, we put that in the meat grinder, these recommendations to not screen sound pretty darn good. And I'm not going to do it because I can't get to the process of doing this correctly. Remember, we're still on the ugly and the bad part here. We're going to get to the good part. But the question is now, what if the recommendations are wrong? We have to scratch our head on this. Okay, we're saying don't screen. What if the recommendations are wrong? And this paper from 2015 in JAMA is really important. It's a wonderful paper. And I want to read this paragraph. I don't want to read slides, but I want to read this paragraph. Both the incidence of early stage prostate cancer and rates of PSA screening have declined and coincide with the 2012 United States Preventive Service Task Force recommendation to omit PSA screening from routine primary care for men. Okay? Longer follow-up is needed to see whether these decreases are associated with trends in mortality. So I've been showing this slide for a long time because we're saying get rid of the screening. That's what the task force said, but we need to have long-term follow-up. And here's our long-term follow-up. Look at the red here, the consequence of being wrong. The incidence rates have increased for regional and distant stage prostate cancer. This is in the NCI annual report that just came out this year. Let me read that again. The incident rates have increased for regional and distant stage prostate cancer. So if you talk to the urologists in any place, they'll say, look, they're seeing more aggressive disease, patients with worse outcomes than they were seeing before. And it brings me back to a slide that some of you may have seen before. Now, this is a slide, the Welch study in 2015. This slide has been used a lot, but I combine it with a quote from a friend of mine, Len Gamella. And Len wrote this wonderful paper in an opinion piece where he said, dare we go back to the pre-PSA era? Because with the introduction of PSA testing, the death from prostate cancer was reduced 20%. And metastatic disease was reduced in half. And that's what you see here in 2005 and 2010. This was the incidence of metastatic disease before PSA. So dare we go back to that pre-PSA era where the patient presents to the ER with excruciating back pain and you're like, oh, well, you've got metastatic prostate cancer. We better call the radiation doctors. Do we want to go back to that phase? And I will tell you, this is the bad thing is if we go back to that era. The ugly thing is if we go back to that era. But if all we had was PSA, we have a bad argument here. So maybe we need something more. Maybe we need a smarter way to do this. Now we're going to be going into the good part. What do we know? Well, we know we have to simplify this. We have to ask the question, can we simplify it? And the answer is yes, we can. But let's challenge ourselves to look at this. If we are to simplify the process of prostate cancer screening, we need to decrease those needless evaluations. We don't want to be doing a million biopsies to save 50,000 people. I mean, that's where the numbers get rough. We don't want to make unnecessary patients. And very importantly, we don't want to ask the primary care provider, that is the guy doing the majority of, and guys and girls, doing the majority of the prostate cancer screening, to have to counsel outside of their comfort zone. We can't do that. So how do we make the primary care provider happy? How do we do that? Well, we have to have information that is based on evidence and beyond any dispute. We have to be able to give the patient a clear framework for a decision. All right? This is clearly the way you're supposed to go. And it needs to be appropriate for primary care. Don't assume I'm going to have this detailed knowledge of the disease the way my urologic oncologist is going to have. And don't think I have the 20 minutes. I might have a few minutes. Might even have less than that because I'm dealing with a lot of other stuff. Remember, I'm doing, tip of the toes to tip of the head. So don't assume I have a lot of time. Well, the reality is, and unfortunately these X's are a little bit out of place, but we don't have information that is based on evidence and beyond dispute, and we don't have a clear framework for a decision. So the question becomes now, can we make a process appropriate for primary care? And at this point, we don't. But I'm going to be teaching you one that we do, and we will. So let's go to a fact. Let's look at this conceptually. If this is how many patients get diagnosed with prostate cancer a year, okay? It's all prostate cancers, the aggressive type and the indolent type. Think about this. This many men die of prostate cancer yearly. Remember, we're 12%. We look at a small percentage. So if we're going to simplify the process, which is what we're working on here, our target is this. We want to be able to affect and help those patients. And that is our sweet spot. So can we find the sweet spot that helps us predict patients who are at risk? So with that being said, Simon, I'm going to take a quick break and maybe take some questions.
Matt, thanks. We've got some good questions rolling in. Some of them you're going to be touching on, I think, in the next section, if I remember correctly. But let's just start with kind of the elephant in the room. We've got 3 different giant societies looking at the same set of evidence, giving us really 3 different concepts. Why are they looking at the same evidence and finding different things or making different decisions?
And I lost you a little bit on that, Simon, but you're asking me, why do the different societies look at it differently? Is that pretty much the question?
Yeah. Basically, yes. Yeah.
I'd love to tell you why. I would love to tell you why. I think we have to look at all of the data fairly. And I don't know that, some of the societies have not necessarily looked at it fairly. This is my personal opinion. Like the United States Preventive Service Task Force should be looking at biomarkers, and hopefully they will in the next iteration. I think there's a little bias with each society. The urologists have a little bit of different bias than the medical doctors. The NCCN might have a little bit of bias. I think that there are a lot of different factors, and the reality is they have to look at how can we, instead of demanding we do something, how can we take the grouping of people that we have and simplify the process? And I looked at the 2012, I looked at the United States Preventive Service Task Force recommendations, and the urologists were having a fit about it. They said, these are terrible. You can't not do this. And I agreed with them that the guidelines weren't good, but I disagreed for a different reason. I agreed that we are making too many unnecessary patients. But where I was concerned is that we don't have the ability for this forced shared decision making to go over it. All right, I disagreed on that. And I also said, look, if all we have is the PSA, then it is a non-specific test. We need to define it better. And that's where a lot of the disagreements come up with the different societies.
Understood. Catherine is one of many asking about our good old digital rectal exam. Where is its place? How often should we be doing it? What do we do for the patient groups that don't want it? Talk about that for a minute, if you don't mind.
That's a great, Catherine. I love that question. Thank you so much. I get asked this all the time. I am a big proponent of the DRE. Absolutely. Because the DRE gives us so much more information than just the prostate. In fact, it really doesn't give us a lot of prostate information itself, if you think about it, because the prostate is a round organ. It's just abutting the part of the rectum where we can feel the prostate on exam. So we're actually only feeling a slice of the orange when we feel the prostate. All right. So in that sense, I mean, you obviously can't get your finger around the prostate, but you can get some information. You can get size, bogginess, pain, and since nodules, when they occur in the peripheral zone, if it's there, you might actually catch it, and you could change the trajectory of that patient of what's going to happen here. But we're also doing a rectal exam for tone, for blood, for lesions. There's a lot of things we're doing there. So, and DREs are free exams as part of a physical. It doesn't cost any more money. It's easy to do, and it gives you information. The problem is people don't like it, right? People don't like getting a rectal exam. I get it. I totally understand. I mean, women don't like getting pelvic exams either. But I'm trying to help you here, and if I can get more information and help you in the long run, I think that's great. I think advocating that our patients don't get that exam is the wrong thing to do.
Makes sense. Thanks for that guidance. Where does family history fall in all of this? Does it make a screen earlier? Does it put someone in high risk categories to go straight to other testing?
I'm sorry, Simon. Where does the what part?
Where does family history play into kind of the risk assessment and judging what to do with screening?
Yeah, that's a really good question. So let's take the look at the risk of prostate cancer. We know there's a family history risk. We know there's an ethnic risk. So does that change things? And it may make it that we start screening a little earlier. In fact, I'm going to show a guideline where we say if you have enhanced risk, maybe we want to start a few years earlier. But there's still a lot of question on that. That's what I would recommend. In fact, I'll show you an algorithm where we start screening at 45 if you have risk, family history, ethnic risk, maybe we start at age 40. But what's interesting is the risk is what brings you to the table, and the table is whether or not we're getting a PSA test on you. All right. And that's the bottom line. And one of those who believe getting a PSA is appropriate in the right patient, I would say that's more important than even looking at risk. I think every male is possibly the right patient when we look at them and their life expectancy. So bottom line, kind of a long-winded answer for the question, but risk plays a factor, but the biggest risk is being male.
Makes sense. Makes sense. So a couple of our learners who talked on, Emma is talking about women seek out their physicians for you mentioned yourself for yearly female exams. Guys don't really seek this out. And, why do you think that's so?
Why do men
Is this a
seek this
patient
out?
education issue? Do we need? So women will seek out their gynecologist for that for
Oh,
their yearly female exams, for their yearly pap screen. But guys definitely aren't seeking out their physicians
yeah,
for their yearly prostate
yeah.
checks.
Well, yeah, that's a really good point. Men are terrible at being patients. We see that all the time in the office. In fact, there was a wonderful study, and I'd love to be able to quote the author on this, but married men live longer than single men. And the reason for that is their spouses are encouraging them to go see the doctor. And I think any of the clinicians in the room will agree. They've had guys come into the office or they're physical, and you're saying, "Why are you here?" Or they're saying, "I'm here because my wife made me come." You don't hear single men saying that. Unfortunately, men don't seek out healthcare, and they have to be prompted to do so. In my practice, men will come into the office for a myriad of reasons. We're very adamant of this is why we do this. At the end of the day, I will tell my patients, I'm hoping your physical exam is the most boring day of the year you got. I don't want to find anything, but I do believe we should be screening you for some things because I want to be able to change the trajectory of things that could affect you. That's the bottom line. And prostate is one of those. Done appropriately, I could change the trajectory and help you if you are one of those patients who are at risk. Let me do that same. But the same goes for diabetic screening and cardiovascular screening. Again, it's unfortunate when men die of stubbornness because they just won't see a provider. And I think our jobs as healthcare providers, as we work with the communities, is to educate our patients for what they need to do and the timing that they need to do it, with the idea that we're just trying to help you live with a good quality for as long as appropriate.
Indeed, indeed. One last question, and I will let you dive into the second half of this, and that is medications affecting both the PSA and the and prostate cancer risk. We've got some people asking about testosterone. We've got some people asking about BPH meds. Do they affect either risk or PSA values?
That's a wonderful question. So let's start with the meds that you take for your prostate itself. The PSA levels that we have at this point, the ranges that we've used are in patients that are not taking medications. We're probably all familiar with the medications of 5-ARI medications that basically stop the transition of testosterone, dihydrotestosterone. And what will happen is those will decrease your PSA. It actually decreases about 25% of the glandular tissue of the prostate and reduces the PSA up to about 50%. So if a patient is getting screened for the PSA and they're on a 5-ARI, then I may be looking at a lower level, and we'll talk about levels in just a minute. The question about testosterone is really interesting. One of my professors, Abe Morgenthaler, did some really interesting studies years ago where he was challenging the idea, does testosterone cause prostate cancer? And the reason we were thinking about that is the studies in the 30s that were a fellow by the name of Huggins, who ended up getting a Nobel Prize for this, who realized that if you castrated males with prostate cancer, get rid of all their testosterone, their prostate cancer went into remission. So the normal the idea became, well, testosterone, if you give them testosterone, they get prostate cancer. And we found out that's not true. The bottom line is that's not true. Testosterone will not cause prostate cancer. However, if you have prostate cancer, you don't want to be giving them testosterone. Now, caveat to that is some of our patients who have been treated successfully for prostate cancer, sometimes they're put on testosterone if they need it. That is not something I'm necessarily comfortable with. Some of our endocrinologists and urologists are. So when somebody who's had prostate cancer is wanting testosterone, then I might actually send them off for a specialist. Oh, and
thanks for answering those questions. Yes, sir.
So the other thing with that, Simon, that's important is testosterone. When your testosterone your endogenous testosterone is very low, below 180. If you give testosterone, the PSA may go up a little bit, but after 180 or so, you're normalized out. The PSA won't be changed at all. Very important to know.
Okay, great to know. Great to know. Some good discussion there. Let's dive into the second half of this, and I will see you again after the post test for some more questions.
Great, thank you, Simon. So let's look at this right here. 1.5. I actually, in a prior slide deck, I just had 1.5, but I decided to put the rest of the verbiage in. Why, as a primary care provider, is 1.5 NGs per ml the only value I need to know when it comes to PSA? So let's start with that. And in this section, we're going to be talking about the good. What can we do moving forward that's going to help us? So when I was digging into the United States Preventive Service Task Force recommendations and realizing we're having a problem, so I started really looking into this in about 2012 when I was asked to. A colleague of mine, Dave Crawford, said, Matt, we have a problem here. Maybe you and I can work together and come up with a better answer for primary care. Dave is, a very renowned prostate cancer guy at the time out of Denver, now out of UCSD. So as I was doing my research on this, I came across a lot of old information that was really interesting, and it helped me. I mean, people knew this. It was helping me figure out what to do. And when we look at this curve, this talks about the risk of prostate cancer depending on the PSA. And what we know is that the low PSAs, your risk of prostate cancer is really low. In fact, for years, I remember telling people, look, a 50-year-old male with a PSA of less than 1, your chance of getting prostate cancer in your life is kind of not there. It's not going to happen. What we see from a graph like this is it, and you see it in the yellow box, a single PSA measurement at this point of greater than 1.6 is associated with that increased risk. What you take from this slide is as your PSA goes up, so does your risk of prostate cancer. That we know that. But at 1.5, it seems where it's kind of starting and becoming, I don't want to say significant yet, but it's catching our attention. And there's another study, this was published in one of the British journals in 2009. Really interesting study. It basically showed your pre-test probability and your post-test probability depending on your PSA. And for a PSA of 0.5, of 1, of 3, the risk was really low of getting prostate cancer in your life. When the PSA started to go up, your risk went up. Okay, that's pretty logical. All right, it's pretty logical if you think about it. All right, and then this was a study. This was actually by my friend Dave Crawford. He did this out of the Henry Ford system here in Michigan. And what he looked at was, as you see from the title, the 5-year diagnosis rate based on initial PSA. And if your PSA was less than 1.5, your risk of getting prostate cancer is 0.51%. It's very low. But if it's in that early warning zone, and that was the title of the paper, between 1.5 and 4, it went up. It was a 15-fold increase in the general population, 19-fold increase in the African-American population. And when they put this on a curve, they found the maximum sensitivity and specificity is 1.5. So this number keeps coming up as you look at the data, and it makes sense because that's when the risk starts to go up. Now, I think I know what everybody's thinking right now, which is, come on, Matt, PSA 1.5 is really normal. I mean, everybody has that. So why is that going to help me? Well, I thought so too when I was looking at it, and I did a little study. I called a colleague of mine at the Bioreference Labs in New Jersey, and I said, I want some data. I don't need names, but I want to know how many PSAs you processed through your lab last year. I want to know the patients between the age of 40 and 75 who only had one, because if they had more than one, they were probably looking for something. And I want you to just give me a spread. And they came up with 217,000 patients with a value of 0.01 to 5,000. Well, 5,000 is kind of nuts. So I dropped it down to 0.01 to 10, and it only actually dropped off a little under 1,400 patients. And this is the bell curve right here. And the reality is most of our patients have a PSA less than 1.5. Only 27% actually have a PSA of greater than 1.5. Kind of interesting there. So the patients who are at this initial risk, right, PSA greater than 1.5, it's only about a quarter of the patients, all right, who have a risk of maybe something's going on. Let's hold that information for a minute and look at another piece of information. When we look at your new cases of prostate cancer, they tend to come up between about 45 and here you see about 75. You see that curve there. You see it peaking around here. So understanding the age when people get prostate cancer is important for us if we're to simplify the screening process. So far we have 1.5, that's kind of a simplified number, and we have an age as a simplified number, and then this comes to the key point here. Who am I going to screen? And this is where I disagree with the guidelines. The guidelines all give us age. I agree with the starting age, but the ending age I don't necessarily agree with. I would ask any age patient, are you healthy enough that I would treat an aggressive prostate cancer if you had it? Now, I'll give you an example. One of a patient of mine, healthiest patient in my office, he's 84 years of age. He is an internationally ranked triathlete. I mean, the guy is the most amazing specimen of a human being I've ever imagined. I expect him to be running triathlons in his hundreds. All right, crazy healthy, right? So would I check his PSA? I would, because I'm expecting this guy to be around. A guideline that says an age and puts a lock on it, 70 and 75, doesn't appreciate what I do as a primary care provider when I'm looking at the whole patient. In fact, I get a little concerned. I'm a little bothered by the fact that guidelines tell me how long a patient of mine is going to live. They give me averages, but it doesn't work that way. And likewise, a patient I saw yesterday, he's 50 years old. He just had a trach tube for his laryngeal cancer because he's a heavy smoker. He's morbidly obese. He had a bilateral BKA from his poorly controlled diabetes. I'm not screening him for prostate cancer. He's got other issues. So age, as an age cutoff, it doesn't work for me. Excuse me. As a health cutoff, it does. So are you healthy enough that I would treat an aggressive prostate cancer? If no, I'm not going to do anything. If it's yes, it's my 84-year-old, I'm going to do a DRE and I'm a PSA. So now let's put all that together. We have the age when we're going to start, when people commonly get prostate cancer. We have that 1.5, and we have the health, and we have an algorithm. This is a adaptation or modification of an algorithm that I published a couple years ago that basically says this. I start at 45 with at least a 10-year life expectancy. I'm going to go a little lower if you're at enhanced risk, because generally those patients are super worried, and I get it. If they have a DRE that's abnormal, boom, they go off to the urologist. Again, I recommend DREs. But here we get to the screening PSA. And I adapted this because the guidelines have changed. And as I mentioned, some of the things in guidelines make a lot of sense, and some are a little more complicated. So here's a simplified method. We screen the PSA. If it's below the threshold that we recommend, I look at 1.5. If it's below that threshold, do the PSA in 2 to 4 years. We're going to be good. However, if it's above the threshold that you pick, and we'll talk about different thresholds, then what am I going to do? Number one, what have I learned over the last couple of years? Check it again. The variability is out there. It may be high, it may be borderline. Check it again. If it's still elevated, then we evaluate. So I want 2 elevated PSAs. All right. Then we go to further investigation. This is where we're assessing risk, and this is really important. Now, personally, I believe the primary care should be assessing all the risk, but the urologist will do that too. As a primary care provider, how am I going to assess risk? I want to introduce you. Some of you may already know about the concept of biomarkers. All right. Biomarkers look at the total PSA and actually extract out the parts of the PSA that are identified with prostate cancer. It's not going to tell you they have cancer, but it's going to say, you know what, there's maybe some more of this than we would like. They may be at high risk. Or you know what, there's really none of this and they're at low risk. So the biomarkers help us identify high risk and low risk. And if the biomarker identifies high risk, then they get biopsies. So instead of going from screening PSA to biopsy, we go through this process of repeating it twice, getting a biomarker, and then considering a biopsy. And I showed some data at the AUA a year or two ago that basically showed that when we follow this algorithm, we were actually able to decrease our referrals for biopsy by 40%. Let's think about that, 40%. Those are 40% less patients that didn't need to get a procedure, that didn't need to have the complications of and the inconvenience of a procedure, and the cost. So we're really doing the right thing. We're still following them and making sure that everything is stable, but we don't just jump to a biopsy. So this algorithm is really, at least in my mind, what we should be doing. Now, what I'm working on in my next step, just to give you a little preview, is I think this should be in our EMRs. I'm trying to work on putting this algorithm into the EMR to a point that all the primary care provider has to do is decide whether the patient has a 10-year life expectancy and would benefit from surgery if we found something. Then they say, yes, start the algorithm. They get the algorithm informs the patient to get the PSA, gets a second PSA, gets a biomarker. The doctor is involved only if the biomarker is high. Other than that, they fall off and we repeat it. In fact, another way of looking at this, interestingly enough, is we can put all the power into the patient here. Obviously in the US, the patient isn't the one who screens the PSA themselves. It has to be ordered. But imagine if the patient was informed on this and got the PSA on their own, which they do in some countries. They go through the algorithm, maybe through a little app on their phone. And at the end of the day, they're only told to go to the urologist when we have identified risk of prostate disease, of prostate cancer. So when we look at the biomarkers, this is what they were talking about. And I wanted to explain it a little more. Again, what you see here is the prostate. Now, we only measure routinely total PSA, but there's so many other parts of PSA. And again, there are parts of PSA that identify more with prostate cancer. So if we get to see more of that, we identify risk. And the NCCN guidelines have talked about this. And what they basically said, and I'm going to show this on another slide as well, is why is this useful? I mean, the AUA guidelines said this as well, because we want to identify risk for the individual patient, because that helps us identify the high-grade pathology, the risk of metastatic disease. Right? When I deferred 40% of my patients for biopsy, that's because those other 60%, the 40% didn't have identified risk for the biomarker. It was low. It said, the high grade pathology is, the risk of that is low. The risk of metastatic disease is low, right? So we use the PSA almost in the same way we use a blood sugar. And we'll talk about that a little bit too. We screen with a blood sugar. Blood sugar is not a great test. We get an A1C if we want to determine if they're diabetic. We get the PSA, and then if the PSA is abnormal, like the 1.5 we spoke about, then we're going to identify risk with a biomarker, and that the biomarkers that are available are the Phi score, the PCA3, select MDX, 4K, and the exosome DX. Now, I spoke about the NCCN guidelines just a moment ago. The same thing. Do not use this as a first-line screening. We don't want to. We use the PSA. That's the logical, inexpensive way of doing it. We use the biomarker for patients who we would be considering for a biopsy, but we want to identify risk. And there's another component of this that's important for us, and this is a little more advanced, but this is for the patient who had a negative biopsy and you're considering rebiopsying them or sending them back. I mean, we've all had those patients. They come into the office for their physical. You look under their surgical history. They've had 4 biopsies, have all been negative. And they're like, doc, don't check my PSA. It's always high. They're going to biopsy me again. I'm going to have 5 biopsies. We call it prostatectomy by biopsy. We don't want that. I will bet you that if you, in fact, not even bet you, I know this, those guys who have had multiple biopsies for elevated PSAs, when we look at their biomarkers are low. They weren't at risk. They never should have had the biopsy. We don't want to make a needless patient and then keep making them more and more, or keep giving them more and more needless procedures. We want to prevent that. So the position on biomarkers to the NCCN, they talk about the free PSA. They use 3, and the AUA guidelines use 3. And I'm between. I started at 1.5 when I was initially doing this. It's somewhere between 1.5 and 3, and that's an individual decision that each provider is going to make. What are they comfortable with? All right. What they talk about is the Phi score, select MDX, the 4K, and the exosome DX. They talk about, again, patients who've had a negative biopsy. Now, granted, those patients may be with the urologist at this point, but hopefully they're with the primary care doc. And you can remember this conversation and say, hey, if you've had an elevated PSA, before I refer you off again, let's look at a biomarker and see if there's assessed risk. So I just have a couple more slides here, but I want to go back in time. In 2012, when Dr. Crawford said, Matt, look at the guidelines and tell me what makes sense for primary care. What should we be doing? I went through the process. I went through what is the process that the patient goes through. Patient comes into the office. They get concerned. They come to the office. They have a history. They get a DRE, a PSA, and if these are all any of these are positive, they keep going down the route and they get a biopsy. Okay. Now, the United States Preventive Service Task Force and other guidelines have said, hey, stop before the DRE and stop before the PSA. Don't do it. That's not right. That's actually wrong. That's throwing out the baby with the bathwater. The intervention should be before the biopsy. So for all this work I've done over the last 10, 12 years, what I've come to realize is that intervention should be before the biopsy occurs. All right, assess risk. So if we're to move forward on this, and this is the really good part, I start with all the bad stuff. PSA, when we use PSA, we want to use intelligent and personalized decisions. We want to avoid the PSA in test in men with little to no gain. We want to focus on age, focus on health, focus on quality measures, focus on those on risk. Because prostate cancer screening is really important. Please screen. Do it appropriately. It is important if it's done correctly, it's fantastic. It's not the best test in the world. It's a valuable test as a first-line test. Just like a blood sugar is a first-line test when we're screening for diabetes. We're not going to put you on insulin necessarily unless your blood sugar is 400, then maybe we'll think about it. But if the PSA is a screener as a first-line test, it just prompts you to go to the next step, and that's where we have the biomarkers, because they improve screening by assigning risk. The conversation starts at 1.5. Whether you're going to tell the patient then to get a biomarker or follow-up, that's when risk starts occurring. So if anything you get out of this talk today, 1.5 is that focused number that you should remember.
All right, back to the Q&A, Matt. I'm going to try to work through this from the screening all the way through that.
All right. Well, thank you. That was a great presentation. As you know, that was brought to you by the My CME people. I will have information on how you can get your one CME from it, but I thought we'd do our own Q&A, let you guys ask any questions you might have, since we have John and I both on the show today. And if you have questions, go ahead and submit those through the Q&A. John, what were your thoughts on that talk as far as that 1.5 is a starting point for prostate cancer screening? Whoops, hang on. I think got you muted here. Let's see.
Okay, I'm unmuted now.
There we go.
Context is always important. Keep in mind, he is coming from the perspective of a primary care doctor and screening and things like that. Us in the urology space, we're in the they are the patients that we're seeing are referrals from the primary care doctors. Right. So we're seeing a different population. So screening, I think 1.5. I've been a disciple of Dave Crawford for many years. So yeah. I agree that 1.5 for screening, I think is a really good number. Anything below 1.5. Yes, reassess risk factor, retest PSA maybe every 2 to 4 years to try to, number one, economic, right? So there's cost, there's economic cost, time cost, and also anxiety for the patient. Whenever I get my PSA drawn, whenever I get my labs drawn, there's always that little anxiety. Hey, what is the A1C going to come back as? What is my CMP going to come back as? Liver function test. What is going to be my PSAs? There's always something in the back of your minds. So you can't just say, well, we're just going to check PSA on everybody. Being selective in whom you test and also how often you test that person for prostate cancer screening is important. But as the presenter said, it's difficult when patients are so much, I think so much sicker because of the obesity and being overweight that we see here in our patient population and all the associated comorbidities with those conditions. When these patients come into the primary care doctor's offices, they often don't have the time to carry on that shared decision-making that is necessary. As he said, 20 minutes, do this properly for a single condition. When a patient comes in with hypercholesterolemia, diabetes, and other metabolic problems, oh, I'm feeling a little down and I have a family history of breast cancer. So they don't have time to deal with all those, and having a streamlined algorithm to test and using 1.5 as a cutoff is a good starting point.
Yeah, absolutely. I think especially in the primary care, as you said, their job is to refer to us for the further testing. One of the questions I have for you, since I don't see anything from the audience yet, is the repeating PSA. Do you go by a single PSA? I know I've been involved in urology for 40 years. You know, when PSA came around, elevated PSA, you got a biopsy. We don't do that anymore. We're always retesting. What are your thoughts?
So when a patient comes in, this is to the urology office now. Patient comes in with the elevated PSA, obviously get a history, get a family history, do a physical examination. I agree. I'm still a proponent of digital rectal examination, despite some data coming out showing that it may not be as useful as before. But I'm not treating just an elevated PSA. I'm treating the patient, and I'm also asking him about his urinary symptoms, because PSA number is a great marker for the size of the prostate more than prostate cancer, as you know. So
Correct.
I'm asking about his urinary symptoms when he comes in with the elevated PSA. More often than not, he has trouble urinating, but no one's ever had him fill out an AUA symptom score. So when a guy comes in with the elevated PSA, I'm not saying, oh, let's do a biopsy, because that is, cost, right? Risk of infection, around 3% or so. And that risk is sepsis, right? Septic risk, meaning they're hospitalized, they have undulating fever, sometimes they're in the ICU. It's not without cost, not just the financial, but also other health costs. So I don't do a biopsy lightly, even though biopsy can be done very easily. I enjoy doing them. I'm very good at doing them. So the short answer is yes. When a guy comes in with elevated PSA, I'm not doing a biopsy right away. I'm not jumping into a prostate MRI, depending on context, of course. If it's just slightly elevated between 4 and 10, no family history, Caucasian male, I'm repeating a PSA. And I'm also, from that same blood draw, I'm getting a percent-free PSA. So that gives me a lot of information. I look at the overall PSA trend. Past PSA, current PSA, is it going up? Is it going down, or is it stable? And also, what does the percent-free PSA show me? So if it's stable, then, and the percent-free PSA is above 25, then I say, well, go through that shared decision-making. Here are the risks and benefits. This is what I'm seeing. Here's the risk of repeating a PSA in the future, or maybe if you're worried, we can do a prostate MRI. It depends on the patient too. Some guys are really anxious. They want to know more. So I may proceed down the path of a prostate MRI versus someone who's like, I'll repeat that in 3 to 4 months and follow the trend. So it's not just elevated PSA and biopsy.
Yeah, that's a good point. I think a couple of things come in here. Do you use the 4K score test? That's one of those biomarkers that it's available. Do you have a preference over one over the other, or?
There's so many out there. You can go crazy. Select
MBA. The way I think about it,
4K epi score, percent-free PSA. I go by percent-free PSA. It is inexpensive. It does not require any specialty labs. All the labs do it. So I try to keep the cost down for the patient and try to improve that turnaround time for the patient too.
Yeah.
Due to the anxiety factor.
And we order something. We don't always get the labs to do it. Just a PSA with reflex to free in total. So if it's elevated, then they'll go ahead and do the free in total for us. So
yeah, I tried, because there are not enough urologists to go around for 330 million Americans. So I try to be efficient with my time. I want to see the patients who have a problem that only I can deal with. Screening, I try to delegate that to the primary care doctors, the fine folks who do a great job, but I don't generally do screening prostate cancer. If guy coming in just for screening prostate cancer.
Yeah, they're always coming in with a PSA. Yeah, good point.
Yep. They're coming in because of an elevated PSA or family history or abnormal rectal examination or something like that.
And we have another question here. What do you like to do first for further testing for elevated PSA? My prostate score, select MDX, MRI. I think we kind of covered that, but do you have more you want to say on that?
For the stereotypical guy with no significant history and a normal examination, I repeat a PSA and percent-free PSA, inexpensive, relatively speaking, before I do any sort of advanced genomic testing or MRI screening.
Great. Well, great. This has been a great discussion, everybody. Really appreciated your comments there, Dr. John Lynn. Here's a little promo for next week.
Although effective treatments are available, many patients with prostate cancer eventually experience disease progression. As novel hormonal therapies and other emerging agents are introduced earlier in the disease course, treatment decision-making is becoming increasingly personalized, requiring consideration of novel risk factors, molecular imaging, and patient preferences, as well as established clinical and pathological factors. Clinicians must be aware of the recent evidence regarding new therapies and combinations and be able to support and educate patients as they weigh the benefits and risks of systemic therapy. At the completion of viewing this, you will be able to submit for free 1 ANCC contact hour. Join euronurse.com next Saturday.
So absolutely join us next week. We're going to also offer another CE. So this is a good way to keep your license up to date, such as us in Illinois. We have to have 20 every, I think it's every 2 years now. But hopefully you guys find this interesting, and we'll see everybody next week. Have a good one, John.
How do they get the code, by the way?
Go to the euronurse.com website. As soon as I get off, I'm going to upload the information on how do you get your code.
Very good.
All righty. Have a great rest of your summer.